As it relates to serum testing or blood testing, the Dutch model of testing has a few significant advantages. So the Dutch model of testing is a dried urine test for comprehensive hormones. So of course, there's a benefit in terms of the sample collection. A dried urine test can obviously be done in the confines of your own home as opposed to going and getting phlebotomy and getting your blood drawn. The main benefit though is the information that you get. When you're looking at blood testing, you typically have a good test for reproductive hormones. So testosterone, estrogens like estradiol, or progesterone. But we're going to add to that picture. We're going to add the metabolites. So especially as it relates to the androgens like testosterone, we can look at DHT and some of the other metabolites. When it relates to the estrogens, we can look at 2-hydroxy, 4-hydroxy, 16-hydroxy estrogens, as well as the methylation products of those estrogens to see if there's either a phase 1 or a phase 2 issue with the metabolism. That's a main benefit. The chief benefit of this testing model as it relates to serum testing is really on the cortisol side of things. Saliva testing has become a better option for a lot of serum testers because you can establish from the literature that moving from a total cortisol that you get in serum to free cortisol over the course of the day in saliva is a significant benefit. What we've done with our testing is taken it to even another level. So what we're going to do is add into that diurnal cortisol pattern, that daily cortisol pattern that drops throughout the day. You can get that in saliva or you can get that with our urine testing model. But to that, we're going to add the cortisol metabolites. And that is a really important piece to look at because as you look at people in both their free cortisol as well as their metabolites, what you find is that in many cases, the free cortisol tells a different story than the metabolites. Take the case of obesity as an example. Typically, people who are obese make more cortisol, but you don't see it in their free cortisol. The free cortisol actually tends to go down. So you get these dichotomous situations where the free cortisol is low and people are thinking that their adrenals are insufficiently producing cortisol. But when you look in the metabolites at the end products of the cortisol, what you find is there's actually in some of these patients an overproduction of cortisol sometimes. And so to characterize the cortisol well, we want to look at free cortisol over time and add in the metabolites to get a complete picture of the cortisol, and adding to that the complete picture of the estrogens and the androgens, as well as progesterone, and even looking at melatonin as well. And we just simply get a more complete look at the hormones to make the best clinical decisions that we can for the patient.